Conference will now be recorded.
At Bot Image, where I'm at now, I'm the chief commercial officer there. We actually have some initiatives in our R&D side of the house that we're talking to Lantheus and Telix, who make these nuclear medicines, about enhancing or reading PET CT scans or PSMA PETs, and actually doing a better job than the interpretation that goes on now. And so that standby, that's probably a few months away. In when we launch it, it'll be next year sometime before we really do anything. But there are some trials that we're looking at. And we think it's a nice market to get into. We're also, as Rick said, we're going to reach out to ANCAN and use ANCAN as a support group tool for the society to refer all the patients that stop in our patient education day across the different disease states. Just put them into, or point them into, the different rooms that all of these moderators manage and do so well, and give everybody a resource to actually get into. So hopefully, I think SNMMI can actually pony up and help ANCAN out, and just make it better. Just get more resources and more knowledge about it, and get it out in the world. So we're running a big campaign to try to bring a lot of our prostate cancer resource friends together, or advocacy friends together, to coalesce and make sure that everybody's getting the right information. That's, I think, a key, is that you can get information, but you got to get the right information, or at least make it standard. And guys like Howard, who's here, Howard Walensky, is key in getting the word out in a very consistent and accurate way. And it's we don't need to confuse guys when you get diagnosed about what everybody's saying. And there's a lot of changes happening. So again, just takes us all to communicate, takes us all to ask the questions, and find our pathway through this journey. So I'm open for any questions, comments, complaints, questions, whatever you need. Let me know.
So thanks. I'll kick it off, and maybe Ray will say something too. But can you tell us? Can you instruct men who have different MRIs from different points in time and would like to use ProstatID? Yeah. What is the best way for them to do that?
The guys have I saw a draft last night of a formal instruction sheet, and it's what we're going to do is we'll only, if you want to go through Prostate Precision Consulting, the online portal, we just have to now submit a note, send an email note that says, I have multiple scans or multiple images, and we'll only charge for one. Okay, so somebody I saw had a reimbursement, I think today. They zeroed out a credit card charge and that kind of stuff too, because we'll only do one per individual, one charge per individual. But if we'll scan as many of your scans that you need, but we'll only charge you one time.
And if I'm not mistaken, you're not permitted by the FDA to compare scans, but you'll give individual readings on each scan. Is that correct?
Yeah, that's correct. You can't. We would love to be able to do that. However, we have a radiologist on staff that can give you a recommendation. His name's Eric Walzer, and Rick, we should maybe see if we can get him to come and talk sometime.
Yeah.
He's a pretty dynamic speaker and entertaining. So, and he's been along through the whole development of the company. So, Dr. Walzer is available. But really, the biggest thing is to take the data, take both of those readings of the results back to your urologist and back to your radiologist. And it's pretty self-explanatory. They'll understand all of the notations and all of the questions about it. And and then the big key is, if somebody wants to do or they're making a biopsy decision, right? If you're in, obviously we're in active surveillance. So if somebody wants to do a biopsy decision, we highly encourage them to do a fusion biopsy. And if that's the case, you have the MRI. We encourage them to use either, let us know if they have a BK system that's the device that they use to actually merge the images together, the MRI and the ultrasound. And GE Healthcare makes one called BK. Coelis is another company that makes a Trinity, and then Euronav makes a Dynacad device, and that's what they use to actually monitor as they're doing the biopsy. And to make it, what happens is we overlay that image in real time so the doctor can actually see in the ultrasound and on the screen where his biopsy needle is going. And we're doing a case study of one of you lucky guys that has had, I don't know, you guys aren't, you guys from LA, Los Angeles, and we did a same thing, 2 images, and he'd had biopsies both years, and all his biopsies came back with no cancer, not even a Gleason anything. It was just normal tissue. And he actually ended up this year with a PIRADS 5, Rick. And the reason is his tumor, as you've seen some of the images, his tumor was shaped like a horseshoe, and all of the needles that they were putting into as a biopsy, literally we could see the scars on the MRI. They were missing the tumor that was very contained. The lesion was very dense and very contained inside the prostate, but none of those biopsy needles ever impacted it. And so we're writing up a case study right now on that to show the images and to show the scarring and how we can see these things. Because he probably should have been diagnosed as like a Gleason 8, probably in a PIRADS 4 2 years ago. So it's one of these things where, yeah, we've caught one. Here's one that it's going to be a great case study, that shows the efficacy of why we're doing this, so that you can actually see instead of guessing and looking at a black and white image or whatever. We can actually show you where those dense tissues are and where they need to get the actual biopsy samples from.
So we'll take at max just another 10 minutes. So if you've got any questions, use the hands up function. It's that hand right at the bottom where it says react. But if you don't have questions, we'll move into the support section. As you know, we don't usually mix education and support, but this isn't really education. This is more clarification than education. We did a session. I'll put that session, or maybe one of the moderators, if you missed it, we'll put that session in there. So Jeff Coleman, you're up.
I'm up. All right. Hey, thanks for the information, Mike.
No problem, Jeff.
Thank you. Yeah, again, you mentioned 2, 3, 4 specific systems that urologists utilize when they're using the biopsy, and whether this bot image can be interfaced with that, right?
Yes.
Would you perhaps be able to email out or a list of those exact systems that somebody could get a hold of? Because I'd be curious then to maybe ask my urologist if they utilize those systems, and then ask them if he'd be interested in, after my next MRI, to use the bot image, and get him those images to utilize. So I guess they wouldn't want to know exactly, the exact names of the systems. Yeah.
No, we can get that to you. That's easy to do, Jeff, and I'm happy to do that. Also, if you're in good stead with your urologist, you can tell him if he wants to order our imaging, he can order it and actually get paid for it. Okay, so he can order an image and he'll get reimbursed from your insurance company or from Medicare if you guys use Medicare. If he applies the right CPT code into his into the order forms, and we have all those. We're happy to send that out to everybody as well.
Okay.
Bing, when we're done with your session afterwards, could you maybe just cut and paste the names of those into the chat window, and then we'll put them along with the reading, and guys can see it. I'm not going to ask Bing to do it right now. Howard.
Howard has his hand up.
Howard.
We can't hear you, Howard. You've got the wrong microphone selected.
We do hand signals here.
Yeah, try and get that. He's working on it. Whilst he's working on it, I want to go to Ray, because I know Ray had a little bit of trouble, but I think he's been sorted out, and hopefully he's seen all his different images. Yeah. And Ray, you want to make a couple of comments?
I think actually they're still looking into it, so it'd probably be better at next week or something for me to give you the final resolution on it. I think that would probably be the best thing, because they're still looking
Ray,
at it.
I just saw a debrief from your stuff, so you should have answers. You should have everything this evening. I just saw a note that went by. Okay.
Okay, so so then might as well just wait till next week, and we can give the full story. So
yeah.
Okay, but I think Ray was. Go ahead, Bing.
No, he'll get results. Ray, you'll get your results this evening. I just saw a note that they wanted me to read before they released them, so you'll get them this evening.
Okay. It's that's fine. So
yeah. I think Ray was one of the poor guys that sent in a number of MRIs, and this was before we'd sorted out the problem. And then something came back, which read one of his early MRIs and told him he didn't have anything there when he knew he had something there. And that was the source of the confusion. And we're trying to, I think Bing sorted that out, as he mentioned at the beginning. Howard, can we hear you now? No.
That's rare.
Yeah, really. Howard silent? You got to be kidding me.
Sorry. I know my mic was on. I'm sorry.
Yeah, he put a message in the chat.
Well, you got me on the hot mic, but I know what I mean. You can't hear Howard?
Howard put a message in the chat.
Yes. Yes. So Howard had the same thing. Howard, you can always call in, and then we'll leave your phone on, call in, and then we'll hear from you. And the question, Bing, is, and maybe we can answer it because we are recording, so it'll be on the recording. He says that he heard from somebody who sent him multiples and only got a result on one. What should he do now?
Yeah, and I said, because the system only takes one at a time, we're trying to change that so that there's multiple folders on there. It's not there, but Howard, just have him reach out to me. You've got my email there. Just have him send me a note, and I'll get it resolved. We'll talk to the engineers and get it done tomorrow, or whenever he sends me a note. Okay.
Thanks. Frank, you have a question. Are you there, Frank? I can't even see. I can't see. Oh, I can see your icon. Frank, can we hear you? We can't seem to hear you either. Guys, if we cannot hear you, go to that cogwheel at the top right and make sure that the microphone you are using is the one that's selected up there. GoTo has a habit of switching microphones. It does it to me all the time. So I check my microphone before I come on. Frank, can we hear you? Speak up. Sounds like we can't hear you. Make sure your microphone is selected. Let's go on to Joel and we'll come back to Frank. Frank, check the right microphone is selected. Joel, are you with us?
I am.
Great.
Can you hear me?
Yes.
We do. What's your question?
Okay, good. Yeah. Mike,
Sure.
so I just had my second MRI this week. Are these scans that, if I were to send them to you, are the scans any less good for you to run through your process if they were done on a if they were not done on an MRI machine that is not a T3?
They're fine. We can do 1.5s, 3s, and there's actually a new one out that's a 7T. But we're good on any of those machines. We're qualified, and we if it's a 1.5.
Yes.
We'll look at it, but if it doesn't produce a result, we won't give you the results. The reason why there may not be a result is if they don't have the settings correct on the machine. And it's not for ours, it's just for anybody reading the machines. There's certain standards, and it's on the Precision Consulting or Prostate Consulting website that show exactly how their machine needs to be tuned to get you a good image. And that's whether you're using our stuff or just getting an image at all. But Joel, we're happy to take a look at it and make sure that we get you a good result.
Okay. Any other questions? Frank left. He's probably gone out to come back in again. We'll just give him a second. Anybody else? One thing that I'll just let you know. Props to Howard. And I also responded, but we've recently responded to the AUA on some new guidelines that they have. And we have slammed them for not insisting on fusion biopsies because they're still saying that non-fusion biopsies may be done. Actually they word it the other way. Fusion biopsies may be done. And we've said to them, they must be done. There's no place for a blind biopsy in today's world. The problem is that not all urologists have, especially in community practices, particularly in community practices, have the resources at hand to be able to do fusion biopsies. And they're still covering those guys' asses, and it's wrong. And I put that in black and white. From me, I can't tell you exactly what Howard said, but we both have taken the opportunity to say, no, this is not right. And it's, in fact, I can tell you, I told them that it's inhumane to subject a guy to a blind biopsy in this day and age, and then he has to go back 3 or 4 months later and do another biopsy because we found something that the blind biopsy missed. It's criminal.
Yeah.
And not that they'll take much notice of me. I'm not their favorite flavor because I tell them like it is. But that said, I'm glad that we had the opportunity to comment. Mr. Schrate, did you want to say anything on blind biopsies and the AUA? Jim may have stepped away. I know it's one of his favorite topics. Ray, you have your hand up, and then we'll try Frank again. Go ahead, Ray.
Yeah, no, I wanted to ask you, the AUA also changed their recommendations for confirmatory biopsies from 6 to 12 months to 12 to 24 months. I just wanted your opinion on that.
Oh, I think it's good, but I'm not an expert enough to give you an opinion on that. But I would rather see the confirmatory biopsies pushed out a little bit. I can say that. That's my own opinion. If I was in your situation, and the cancer was relatively benign, I'd want to push it out as far as I possibly could. Howard may have an opinion on that if we can get Howard in. Okay, 2 more questions. Howard, can we still not hear you? No, because I would have asked Howard to comment on, maybe he'll put something in the chat window as to what he thinks about how long it should be on these confirmatory biopsies. We're going to take We're going to take two more questions, and then we're going to move into the session. So, Frank, can we hear you now?
You hear me now?
Yes. Yes.
Good.
Success.
There was a technical glitch and I lost the connection. And when it brought me back, I guess it didn't turn on the audio or the camera. So I had to log off and come back on. Okay. So my apologies if I ask a redundant question because I was listening, coming in and out of the discussion. I have an MRI, has both with and without the contrast, and I did ask if they could separate those, but they cannot on the CD file. So is that okay that the file that I forward has both with and without the contrast?
That's fine. Yeah, we will actually, we prefer not to use contrast, but we can take contrast, and what happens is the system knows that it's there when we mark it, and it will kind of just ignores it, just erases it from the data.
Okay, and then I heard some comments about technology, and I didn't hear all of it, but I don't know what technology they use for the MRIs. Does that matter?
No, doesn't matter.
Okay, thank you.
Yep.
Okay, and we'll close out this segment with Dr. Dan. Come on in, Dr. Dan.
Hey, Rick, thank you. I hope according to my screen, you can hear me. So I'm gonna
Yes,
go.
we can hear you. Yes.
So you touched on something that is a huge conundrum for all of us AS patients or anxious surveillance patients, and that is, most of us, given like I'm a 3+3, I don't have anything visible on my MRI, which is great, but my urologist is constantly pressuring me to do the quote unquote confirmatory biopsy. And I said, well, it's just going to be another blind biopsy. I said, tell me if it comes back negative, you're going to tell me I don't have cancer? And he says, no. So I really agree with you that we should only be sticking in needles and things that we can see, especially based on this interesting case report that was presented tonight. But I'm guessing that most of us who have urologists or involved with urologists are getting some kind of pressure about doing the confirmatory biopsy, whether it's in 12 months, 18 months, it doesn't matter. Most of us, I'm guessing, are not going to have a targetable visible lesion on our MRIs. And I'm glad you wrote to the AUA because it's a tremendous amount of pressure. I mean, I'm a physician and I feel constantly, I hate to go in and see the urologist because I know he's going to want to stick more needles in my prostate. So just wondering what others have thought.
And I'm going to go to Phil because Phil has an opinion on this. He's from true peer experience. Phil, please.
Well, I've had 5 biopsies, and certainly when I had my biopsies, I'm not sure I really understood. So I was happy to follow my urologist's way of thinking. But certainly over the last 6 or 7 years, I haven't had a biopsy, and I won't have a biopsy because my MRI and my micro ultrasound both don't really show anything. So why have a biopsy?
Okay. And Howard, can we hear you?
I think so. Can you hear
Yes.
me?
Yes.
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 Howard's
Yes.
back.
But let me ask Phil, or Bill Wood for that matter, with Dr. Klotz up in Toronto. I believe he spreads out these biopsies for 5 years, right?
Well, up to 5 years. I think he uses 3 to 5, but I mean he's not opposed to going as long as he can. But I'm not sure that I still think he's a confirmatory biopsy, 12 to 18 to 2 years. I think he's still pretty well stuck on the sort of the standard for confirmatory
Was
biopsy.
it a pun there with stuck?
Yeah, exactly. But I guess things like I agree. I think things definitely change with with the MRI. Before there weren't people weren't doing MRIs, so they just followed up the biopsy. They just followed up the initial biopsy with another biopsy, be it even a blind biopsy. But now I agree, if an MRI doesn't show anything, why bother sticking?
I just read an article by Klotz calling on the urology community to get rid of the biopsy in general. So
unless
I'm not trying to compete with you, Phil, but I hit 6 of those suckers.
Yeah, I know.
And I had one more than you, but there was an advantage to it. The guys who followed us didn't have to have as many. We were the guinea pigs.
Yeah.
And they learned a lot about how our prostates act and react. And so I haven't had one of them since 2016. And I finally had a parametric MRI because I had a claustrophobia issue. And I finally did that. That was the first time since 2016. And that's how I'm being monitored now. That and the PHI test.
But Rick, you touched on something really important. As long as the societies like the AUA have it in their recommendations, these guys all feel like they have some risk of being sued if they don't follow the official recommendations. So I hate to say it, but I have a little bit of sympathy for what they're going through. But in general, urologists are surgeons, and they get reimbursed for doing invasive stuff to us. So, I'm glad that everybody here is sort of, on the same wavelength about, not doing a whole bunch of blind biopsies.
And you know what they make their most money on?
No.
Biopsies. It takes the least amount of time and makes the most amount of money. So there is certainly in the United States, there's an incentive.
Yeah. Okay, Ray, and then I'm going to hand it back to Gary to check who needs some time tonight. I don't think we have any newbies, so that'll save us some time. But and by the way, if we have time at the end, and if Bing's still around, then we can go back to him. But we want to make sure we get plenty of time to support everybody. Ray, you're up. You've got the final word.
Can't hear you, Ray. Can't hear you.
You're muted. You got to unmute, Mr. Evans.
Sorry. There we go.
That's okay.
I was just going to point out that even though the AUA changed their guidelines, there's still a lot of urologists that are pushing to do a confirmatory at 9 months, at 12 months. Yeah. And even at the conference, I asked that question about changing it. And the doctor said, well, if I was confident in the first one, I might go 2 years. I could see waiting 2 years, but that was his response, because he kept saying 12-month confirmatory biopsies, and I asked him about the change in the AUA. So I don't know. I think it may be somewhat economics or something, but even with the change, you're still having everyone kind of pushing the 1 year, and I'm not sure exactly why. So with no change, or even actually less, in my case, a lesser change. So far, we'll see what Mike's company comes up with. But so far, with PSA dropping and no change, that I was recommended at 9 months or 1 year to do a confirmatory. So.
Okay. So guys, Richard, I'm sorry, we've got to move into the regular section of this, but we will come back to you, and maybe you can ask your question and ask for some time, and you can do it then. Gary, I'm going to pass over to you. Check who needs some time tonight, and move into your regular section, and we'll go from there.
Okay. Well, good evening, everybody. And Richard, good to see you. And I put you down for some time, if allowed. Well, it's the second meeting of the month, so it was recorded. You heard that right in the middle. I just wanted to reiterate, it is getting recorded. If you have a problem with that, you can turn your camera off, you can change your name, you can do whatever you like, but this this meeting is being recorded. Welcome to the ANCAN Active Surveillance Group. And first, I'd like to thank the sponsors who help make this possible. Bayer, Novartis, Johnson & Johnson, their division Janssen, Myriad, Telix, Blue Earth Diagnostics, and Foundation Medicine. Now, after that fine intro from Rick with Mike, I'm sure everybody on the screen is in the active surveillance group. If you've been treated or you're being treated, you're more than welcome to stay, but we don't talk about treatment in this group, and we have groups better suited for your needs. So I'm going to go down the list real quick. I think we're going to come up with a new system, but I'm not familiar with it. We tried it last week, and to be honest with you, I can't remember. So we're going to do it the old way. And when we change it around, that's the way we'll do it. But old school, I didn't remember. Michael, good to see you. Do you need any time? You're muted, Mike. Can't hear you.
No time for me. I'm here to listen. Thank you,
all right.
Bill.
Jeff, do you need any time? Jeff Coleman? Where'd Jeff go? Jeff gone?
I think he left.
Okay. All right. Frank, do you need any time?
I do not. Thank you.
Alan, in the Big Apple, do you need any time?
No, I'm good tonight. Thank you, Gary.
All righty. Mr. Keller, up there in Jacksonville, do you need any time?
I'm good.
Okay. Ed Moyers in Virginia, good to see you. You need any time?
Not tonight. Thank you.
All righty. Dan, on the other side of Florida, do you need any time?
No, I'm good. Thanks, Gary.
All righty. Mark Mizarek, do you need any time, sir?
No, not tonight. Thank you.
All right. Richard, I got you down for some time. Bill Wood up in the North Country with Phil. Do you need any time, Bill?
No, I don't. Thanks, Gary.
All righty. Good to hear you. Ignacio on sunny California. You need any time?
Not today. Thank you.
All righty. Bill from Virginia. Do you need any time?
Not tonight. Thank you.
Okay. Dan, Dr. Dan, do you need any time?
No, I don't. Thanks. I just want to comment. I heard a couple of people commenting about questions about MRIs. Someone said they get claustrophobic.
Dan, can I cut you off? We'll come back to you. We'll give you some time to talk about it. Let's just get through everybody. Okay,
gotcha.
Mark him down. Mark him down.
I got it. Joel in Manassas, do you need any time? Joel, you're muted. We can't hear you. Do you need any time, sir?
No, I'm fine. Thanks.
All righty. How about Ken in Chicago, Hockey Town?
No, thank you, Gary.
All righty. And I believe Jim has left. Good to see him when he was here. And Howard, I don't see Howard. Okay.
Jim Schraitz still with you, still with us.
Okay, well, he's not on the screen, so therefore he must have turned
Yes,
off.
he is.
Good to see you, Gary. I don't need any time.
Okay, same here, Jim. Same here. Howard, are you still with us?
No, it doesn't look like he is.
No,
Okay.
Howard left.
Well, Greg Burns, I don't see your face, but are you with us, sir?
No, he left too. He's probably going to come back, but he left too.
Okay, and Ray Evans, do you need any more
No,
time?
I'm good.
You're
No,
good.
I don't. Yeah, I'm good. Thanks.
Okay, well, Richard May and Dr. Dan are the only two people that are requesting time.
Wow.
So we can get to Richard. Go ahead. Richard, are you there? Richard May?
I don't see his, I don't see him on the screen, though. He left something in the chat, Gary.
Okay. Okay, I'm just looking at it right now. I guess it was his opinion, his opinion in the frequency of procedures. And he's
Yeah,
mostly
so
right.
let's read what he put in there, Gary. Why don't you go ahead and read that into the record?
Richard said, a factor that may be considered in regard to the frequency of procedures can be economic for both the physician and, if employed, the entity the physician is working for. When I negotiated the compensations of the physician's employment contracts, their bonus was calculated on the number of WRVUs that they produced in a year. A biopsy can generate a substantial quantity of WRVUs. So I guess that coincides with what Howard said, is that the money is in the biopsy, or that some of the money, not all of the money.
Yes. And what are WRVUs? Maybe Dr. Dan can tell us what WRVUs are.
Never heard of them.
Oh, okay. Okay, Bing, any idea what WRVUs are?
So Rick, I would say
See, value
RVUs are
unit.
just a measure of work.
Yeah, it's the big clinics, they call it a work relative value unit. It looks at time spent, technical difficulty, physical, mental effort, and stress due to risk to the patient.
Well, I'll just make a comment as far as WRVU units go. Now, I don't know how much you're getting paid for a DRE, but that should have been out the window a long time ago. So maybe that's why it's getting phased out, because they're not making no money for the 3-second insertion and release.
Yeah.
Anyway.
Exactly.
But okay, work related.
I will tell you on the subject of DREs that this new guideline we looked at is discouraging the use of DREs unless there's an exceptional reason. So finally, AUA is getting on board with that.
Well, that's good, because when I go up to Jacksonville, this guy always likes to do the DRE, which I don't really have a problem with it. It's, to me, no big deal. I don't really have a problem with it. But of course, I've come to learn that it, really has not a value that's worth. So I'll mention that to him when I go. All right. Well, Richard, I read his comment and we made a little. So evidently, there's some money in the biopsy business. That's my takeaway. And Dr. Dan, you were talking about the MRIs. Go ahead.
Yeah, I just want to. I mean, I get claustrophobic too, and I found out that a half of a 5 milligram Valium tablet works wonders. I fall asleep in the machine. You do have to have somebody to drive you home, but it's not worth sweating out getting in there if it makes you nervous. They're getting bigger and bigger bore machines these days that'll feel less cramped, but I don't know, not everybody may have access to those. I would say that if you go to a place that's an independent MRI facility, they should have a specific prostate regimen that tells the tech what things to do and for how long and how to collect the data. And of course, you're going to be putting a collection device over your bladder. I mean, thank God in the old days they used to go in your rectum, but now it just goes over your bladder in most places. So all those things should be happening. And one other thing I would mention, it is great that most of the experts I've spoken to agree that you get about maybe 5% more bang for your buck with gadolinium. Gadolinium, first of all, gadolinium is not one thing. The contrast me, there's a bunch of different gadolinium products on the market, and the newer ones may be safer, but there are some not so great side effects associated with gadolinium. And if you're getting a scan every year, I don't know how much of it builds up in your system and where it goes. So if you're nervous about that, just tell them you don't want it with gadolinium or with contrast, and that you get 95% of your bang for the buck. So just thought I'd mention those things.
Well, that's great. I know Mike's got his hand up, but I want to mention Harold wrote a really good article on biparametric versus multi-parametric, and I guess they talked about it in the PCRI. And there's no, I think the general consensus is that if you an AS guy that they really haven't seen much, there's no reason to use the contrast. My guy likes to use it, and I've said no. I've said whatever to this point, but the next time I go, I'm going to tell him we're not doing contrast because I have to take a whole goofy pill to get in the tube because I'm extremely claustrophobic, and that adds about 20 minutes onto the scan by coming out, going back, this and that. So I'm looking forward to a shorter scan the next time I go up there. And it seems to be the general consensus is that you don't need contrast. And of course, the bigger bore machines, now maybe Mike can answer this for me. You know, we even have a sit-down MRI in Melbourne, Florida. You sit down in this thing. There's only one of them. And of course, I thought I was going to be all for that, sit down and maybe I wouldn't be so, but of course the resolution would not be good. These larger bore machines, I imagine they're 3T. Do they get the same resolution? I thought the bigger the bore, the lesser resolution there is.
No,
Mike, you got something on that?
Yeah, the 3T and 1.5Ts, what they're doing is it takes longer in a 1.5 versus at 3. What's going on is it's staring longer and it's receiving more of the energy over that period of time. But a contrast is not going to help. Howard's article was right. It was great. For what you're doing with the prostate, there are other reasons why, and I think Dr. Dan, you can probably chime in too, but there are other reasons why you'd want a contrast, but not for a prostate. And also, if you have any kind of renal issue, you need to tell your physicians that you're not going to be doing contrast because it can cause some pretty significant issues if you're not careful. Again, that's just being open with the doc and making sure that he knows your conditions and your other comorbidities before you go into that stuff, because gadolinium is not good for your kidneys.
And as usual with this group and ANCAN in general, we strive to tell everyone that you have to be the best advocate for yourself. And the more knowledge you can gather from these peer support groups, reading the Act of Surveillor, other documents, other things that come out that are always put into light by ANCAN or Howard in the Surveillor or whatever, enables us to ask more questions, to better understand, and to turn around and say, no, I don't want that. We've had people come and they want to do a biopsy without an MRI. And we tell them, you got to go shop someplace else. That's ass backwards. You can't do it. And it's still being done. We still have new people come on board and they say, oh yeah, I had a biopsy, then I had the MRI. And of course, all of us are dumbfounded, but that's, there's nothing we can only help when they come into the group and encourage them to come back each and every week, because there's always something new. How swift, how it's changing, diagnostics, the AI thing. We just talked about that with Dr. Epstein. It's just, all of these things are going to influence what people can do. And the more you know, then you can ask or you can tell them what you want done. But you have to be knowledgeable. And that's where this group comes in handy. I know, David, I don't know if Rick saw you wanting to, somebody perhaps in Colorado. We have a little time here. If you want to mention them to him quick. And I don't know if Howard's listening, but Howard can also be the directory for the United States of America to find somebody that can take care of you. So, he might be a good resource.
Before we go to that, I just want to make a comment on this blind biopsy, because the person I had in mind when I wrote that comment is with us today, right here in this room. He came to us and said, I had a blind biopsy, and we sent him back, and he went back and forth with his urologist, and then he moved and he went over to Mayo in Jacksonville. And now, I don't know if he did yet or he will, but he may have to undergo a second, or he did undergo a second biopsy. He'll tell you if he wants to tell you. He'll come on and he'll tell you. But that was who I had in mind. It's crazy that that we result in 2 biopsies here when we just didn't need it. It's just wrong. And so
just ask your urologist if he wants to do a blind biopsy. If it comes back negative, if he'll tell you don't have cancer. And he'll say, right. Well, no, I wouldn't say that. So you should say, so why should we do it then?
That's right. I see you switched your mic on, Dan, so maybe you will say something.
So I haven't had another biopsy yet. I did have the MRI and it confirmed a lesion, but my doc was supportive of staying on active surveillance, and he's talking 12 to 18 months. I wasn't aware of the AUA guidelines, so I'll go back out there and we're going to do another MRI in about a year, and then we'll talk about whether or not we do a biopsy or not. So as far as I'm concerned, we'll push that out as far as we can. I'd rather not have any needles stuck in me, but
no.
Appreciate you putting that note in, because yes, that's exactly. And not only that, but the guy wanted to do, after we did the biopsy, confirmed cancer, and did genomic testing, he wanted to do another blind biopsy without an MRI, and discounted my concern and discounted my request for an MRI before we did the biopsy. So that's why I moved to Jacksonville.
Well, I was not aware of the fact that Howard brought to our attention and what Richard Moyes stuck in the chat window, but evidently these biopsies are the most profitable thing they can do in terms of, money and time. So yeah, it's no wonder. And it's also no wonder why the AUA is not insisting on fusion biopsies. And it's criminal. I don't have any other words for it. It's a racket. And we have to do our best to speak up. And again, I gave props before to Howard. I'll give props to Jim Schrate, because Jim has always said that the fact that the AUA comes to us and asks for our opinion is one of the greatest privileges we have as patient advocacy organizations, that we can go in there and we can say what we need to say, because no one else is going to say it. Who else is going to say it in the AUA? I've talked to some well-respected urologists. Some of them are on our advisory board. If you're a urologist, you don't want to get up and say and criticize the AUA. Jim, go ahead, please.
Yeah, we need to be on record as saying this. We're not going to get it changed. We didn't get it changed in the last round. I don't think we're going to get it changed in this round, but we need to make a record on behalf of patients that this is what we think the standard of care should be. Because I totally agree with you, Rick. It's certainly malpractice, if not criminal. These resources are out there. This should be the standard of care. And, it's not getting there for reasons that really don't have anything to do with what's best for patients.
Go ahead, Dan. You're muted right now. Unmute.
Can't hear you, Dan.
Sorry about that. So, yeah, so it sounds like a lot of us have been in the same boat. I just want to say a couple of, I think, generally supportive things. There is a thing called the NCCN, the National Cancer Care Network, or something like that. And they have diagnostic algorithms for every kind of cancer. Prostate is just one of them. And if you go on there, it says biopsy or MRI. It says biopsy / MRI. So there is, but that's a medical group, not a urology group. So there is some support for doing following these things with MRIs. The other thing is that when I got my diagnosis, I quickly hunted around, and luckily I'm in San Diego, and I found Mark Scholes, who's up in LA, and most of you may know his name. He wrote that book called Invasion of the Prostate Snatchers, which is if you haven't read it, it's on Amazon in paperback. You can get it. And it's a good read and it's informative. But basically, his whole thing was that if you're under the care of a urologist, they want to yank your prostate out as fast as they can. And he is a medical oncologist that does nothing but prostate cancer work. And he told me that he's been doing for the last 10 years, he's been following all his AS patients with MRIs and PSAs. And he's very confident that it's an accurate and safe way to follow people. And he's preparing a manuscript to get published in one of the peer-reviewed journals with the folks at UCLA, where I guess he sends a lot of his patients for scans and things. And they're going to write this up with a few hundred patients that they've been following for up to 10 years to show that this is an acceptable way to follow, active surveillance patients. So good news. As someone said, you poor guys who were early on, you got the brunt of the biopsies, but hopefully the rest of us can learn from that.
Yeah, I will tell you. Well, I may not need to tell you because another gent who's in this room right now, we navigated away from Dr. Schultz when it came to actually having a biopsy because Dr. Schultz doesn't have the most up-to-date equipment in terms of giving biopsies.
Well, I'm not that surprised. It's not, like I said, it's not his major way of following these patients. So
right.
Well, I'd like to welcome Marty to the group, and I can see his whole face. Normally I just see his head or his eyeglasses, but I can recognize him just from that. He's one of the few guys I can recognize him just from his forehead and half his glasses, but we got his whole face. So I'd like to say welcome back, Marty. And even though you arrived for the party a little late, do you need any time?
No, I'll just listen tonight. I'll just listen tonight.
Okay, good to see you,
Good to
Marty.
see everybody.
I'm glad you're
Yeah.
here.
Thank you.
Okay, all righty. Well, they were the two people that actually requested time.
I know.
So we've got more. If Mike wants to add anything, or if anybody wants to ask Mike anything about his company and what they're doing.
From an active
the floor
surveillance.
is basically open. Rick, you normally want to plug something? Well, go ahead, Mike.
Let's first go to Mike and please go ahead.
Sure.
Please go ahead, Bing.
From an active surveillance perspective, I wanted to mention that if there's hard data out right now that hasn't done very well at being published. We're trying to get it out more. But if you're a veteran and if you worked in the aviation community, you're at about a 30% higher incidence rate for aggressive prostate cancer. And so it's one of those things where we don't, we've studied now, or the DoD, we finally got them to do this study. They looked at total about 1.8 million, so 900,000 on phase 1 and about 950,000 on phase 2 cohort study of guys with all cancers. But prostate came up obviously in the top 2 or 3. And the average age of diagnosis was 47. Okay, so wow. It's don't start screening at 50. If you know guys that are vets or that are, any of your kids or anybody else, make sure that you encourage them to go get screened, even with a simple PSA, earlier on at, around age 40, 45.
Yeah.
So, I think that's got to be one of the things we're pushing for in the guidelines, Rick, is that our comments are that they've got to take into account, the 6.5 million, or, there's now there's 15 million vets in the country, and 9.5 million or 7.5 million of them are inside the VA, and they're still using USPS, PFTS or whatever guidelines.
Right.
And you've got we're basically saying no need to screen, or we can have a discussion at age 50. So.
Yeah, and also at the top end, which doesn't relate to your naval flyers, but at the top end, they're discouraging from screening over the age of 70, and yet we know that. Look at Biden, where they stopped at 70, and then at 80 something, he's diagnosed with metastatic prostate cancer because somebody should have been following him. What were they doing?
No, that's got to get into guidelines too, because the screening, I mean, it is so easy nowadays, you know.
Yeah, exactly. I will come to. I know we got two hands up. I suspect it's about this military topic, but I just want to tell you that Bing sent me a fabulous podcast. He said you'll enjoy listening to this, and I had some time to listen to it yesterday. It's about he's not so young now, but he was 42 when he was diagnosed with prostate cancer, a naval flyer, just like Mike. And we will be featuring it in the reminders. Hopefully the next reminder, we're going to put it into the AS reminder. We're also going to put it into I think we're going to put it into all the prostate reminders. I think that's what I asked Kiernan to do. It's a great story. And thanks for sending it to us, Mike. And who's that? I forget your doc. He's with the Michigan group, but
Dr. Michael Lutz is his name. He's a recently retired urologist, and he runs. His passion is Michigan men's health, and he needs support groups. So guess what, Rick? And I've got to tell you, they have an annual Michigan Men's Health Day. They do it in conjunction with the Detroit Lions at Ford Field. And this year we screened 3,000 guys in one day, in 6 hours.
Wow.
Nice.
So, yeah. And this is actual screening. And the tests available for the men, it was all free, over 40. They kind of fudged down the high 30s, but everybody came in. You got everything from your eyes checked to your heart checked. They put 2 guys in the hospital with AFib that they caught there on site. You get everything from a skin test for melanoma, kidneys, lung functions, eyes, ears, the whole 9 yards, even a foot check, and your blood and urine are taken. And they did 3,000 of these in 6 hours.
Wow.
They had Henry Ford Hospital and Corewell Health have teamed up to do this, and the Detroit Lions are helping out with it as well. But they had over 120 phlebotomists that were taking blood, and it was amazing. And they took both the Prostate from Ren Labs, which is coming out, just getting through its FDA approval now, and they took PSA, as well as all your lipids and everything else. They processed everything. Biosciences did it, and you know these guys. We're trying to look at. They need support groups. They don't have any support groups. So guess what? I volunteered. And
yes, sir. And you know what's the beauty of our support group is we can take people from anywhere. I will tell you, which is real interesting to me, that in our multiple sclerosis support group, there is a predominance of people from Michigan, and we're national and international. But it is scary how many people in Michigan living with MS, which probably has something to do with the environment and the water. We don't know. We've got some hands up. Let's start with Bill from Virginia. Bill.
Yeah, I joined that second aviation cohort myself just to get some results. I think that the thing that bugs me looking back is this threshold of a PSA of 4, right? When you talk about 47 being the kind of the average cohort detection age, 4 is too late.
Agree. My physician, just so you guys are all aware, my oncologist at West LA VA will do follow-ups at because you're a vet at 1.5 nanograms per milliliter. and that's where he starts to start doing MRIs and seeing what's going on.
I was diagnosed in 2010, and it was only when my PSA went over 4 that my primary care guy said, you need to go see the urologist. And I think
Same.
the old school number is 4, and I thought the new school number is 2. That was my belief, because a lot of people are now, when it goes over 2, they're pushed off to a urologist. At least some of the people that have been in this group. I know it seems to me that they took the 4 and made it a 2. But here again, depending upon who your urologist is and what guidelines they're following, if they're following any guidelines, who's not to know the better unless you're a little bit more knowledgeable about what's going on.
Wouldn't that assume a nominal prostate size as well?
Yes, it
Yes.
does. So, Bill, I was just going to comment on that. So for those of you who are wondering where the heck does the 4 come from, 40 grams or 40 cc's is considered to be the average size of a prostate. And the other heuristic rule is that you generate about 1 unit, whatever it is, mg per ml, but you get 1 from about 10 grams or 10 cc's. So an average 40 size 40 cc prostate should give you a PSA of around 4. Now, there's a lot of fallacies with that. First of all, not everybody produces PSA in the same level. We see that in our advanced groups. We have guys who produce huge amounts and they don't have serious disease. We see guys who produce very little PSA and they have terrible disease. So that's one problem. Second problem is that guys with smaller prostates tend to have more aggressive disease. Maybe because it's easier to find the lesions in a smaller prostate, or it was typically before blind biopsies, before MPMRIs were introduced. And so they diagnose more people from smaller prostates. A lot of those guys, like myself, my prostate was, I think, 20 or 21. A lot of those guys had high-grade prostate cancer. So that's where the 4 comes from, and it's really pretty arbitrary. And I think maybe 2 or 2.5 is right. But if you're a naval flyer, damn, you should be looking at 1 or 1.5, just exactly the same way as if you got prostate cancer in your family. You don't want to start screening at 50. You want to start screening at 40. So, there's a lot of exceptions. Mr. Gifford, you have your hand up. You've had it up for a while.
Yes, 2 things. First of all, it's not just the aviation community in the Navy, it's the aviation community generally. And it's also the nuclear missile career field. The Air Force ended up having to do a study that was dictated by the head of the nuclear command in the Air Force. And they found that both prostate cancer and breast cancer were prevalent in the nuclear community. Spent 3 years underground in the missile business myself. 2, going to the points that you point out, Bing, with the aviation field and younger folks. So I had my most recent job, I had a boss who was a flyer. He was African American. He was over 50. And until I got diagnosed with prostate cancer, he had never heard of prostate cancer.
Yeah, wow.
And the military, active duty, they don't do PSA testing, even for those who are over 40 years old, which I think, based on what you're saying, Bing, that's kind of a travesty that we collectively, Department of War, now former DOD, we're not doing due diligence for those people that fall into the high risk areas. So that's my comment. I don't know if you have any other comments, either you, Bing, or Rick, to what I said.
I agree 100%. There's a meeting that's been called in November to talk about veterans prostate cancer concerns that I'll be attending. But it's one of these things where you're gonna be there. Good. And we're going to push these studies that have been done. You can't argue, and I've got all sorts of oncologists standing up saying that they can't argue with 1.8 million cohort study, right? I mean, 900 and some thousand first time and the same second time. So the data is there. It's very accurate. It's done by Department of War, and so it's okay. Now we need to make some changes. We don't need to go find out more information. We need to do the changes like immediately. So thanks, Bill.
I'm just sort of aghast that in these standard military medical evaluations annual that they're not testing people from the age of 35 and those who are in the military, because there's good reason. The exposure and the exposure is huge. And that seems to be an exception and a good enough reason. And how difficult is it to get a bloody PSA test if they're doing a medical anyway? They're taking blood anyway. Just send a little bit of that blood off for a PSA test and start at age 35. We've got a guy that we're navigating right now. Bing's aware of him. He's 42, I think. He spent 11 years in the Navy. He now lives in Germany. And he has very, very high risk prostate cancer. I think he had, from memory, 10 out of 11 cores were Gleason 4+5. And he's now doing, he's doing 6 months of ADT, I believe, and an ARSI, a secondary drug, and then he may well have surgery. But here's a guy at 42. We should have been testing him when he was 35, and he hadn't been discharged. And it's not good.
I think all the vets on here would agree that the military, I've spent in and around the military for over 40 years, almost 50 years. And the military has rarely done anything that is best for the person in the military. They've done best for the military, but not for the people that are doing the work. So we can go back to Vietnam and before that for all of the things that most of the vets have gone through. I mean, if Jim were here, Captain Jim were here, he'd probably tell you exactly the same thing.
Yeah. And and again, more props this time to Bing, because I don't know that anybody's done more for, at least for prostate cancer in the military, than Mike Crosby. But there's only so much you can do. And I know, but Mike continually keeps shoving it in their face and shoving it in their face and shoving it in their face. But we've got some very stubborn people on the other side. But now with at least with some of the evidence that Mike's coming up with, it may help. Go ahead, Bing.
No, I appreciate that, Rick, but it takes all of us, and I encourage everybody to get involved. And there's a lot of reasons, and I won't get into it tonight, but Veterans Prostate Cancer Awareness is actually merging into a group called Military Aviation Coalition for Health that's coming out. It's just got its approvals and things like that. They too, Rick, don't have a support group. Guess what? They do now. But the deal is that we just have to be the voice of all of us. I mean, we all have to we can't just kind of suffer in silence. I think we've got to get out and ask these questions. We've had a lady, Tara Kopp, so everybody knows, she's a reporter. She's now at the Washington Post, but she's been through the Pentagon and everything else, and a very trusted source. But she's done FOIA requests for the last 8 years that I know of. Continual FOIA requests asking for any test, any research and development test that's ever been done by a private organization, or the public organizations like the Boeings and Lockheeds and everybody, or any of the test commands and requirements development commands to test any effects, both chemical, radiological effects on a human body inside of an airplane. And she's also asked for ships and missile batteries, and I think the missile silos are built. I think they're in there as well. And there has never been a test. We've never gotten a response from a FOIA request on a formal test for any platform on effects of a human inside that platform. And so that's something that needs to be done, and that's one of our pushes. We're pushing. We've gotten actually a lot of support from some congressmen now, Ro Khanna and August Pfluger and some of the other guys out there that are seeing their friends die. And you know, we're going to get some traction, I think, in the next couple of years. So everybody stand by and please stay involved. And I appreciate everybody being in the support group, because it's just another way to get the word out. And yeah, so thank you.
And Bing, if for any reason you need, we have at least 2 people that I'm aware of in the advanced group who served on nuclear submarines.
Yeah.
So just to echo Dan Gifford's point before. So.
Yeah, absolutely.
So. Well, Mr. Tosker and Mr. Siegel, what do you think? And Mr. Schreit, anything else we'd like to talk about with Bing tonight? Thank you for your time, Bing. Really appreciate it. I think the guys do too.
For the job, it's okay. It's that I gotta, earn that salary you're giving me.
Don't spend it in one place.
All right. Yeah. It's not half a warm beer on a bar somewhere is what it is.
Rick,
go ahead, Jim Schreit.
I guess we can actually finish it up if nobody's got anything else. It was wonderful.
I think Jim Schreit's got something to say. Go ahead, Jim.
No, not really. Just good to see everybody.
Definitely,
too,
Jim. Good to see you. Again, Bing, thanks for your time and all the information that you put out. And I know you're an unbelievable advocate of the support mechanism. As you said, it's how to get the message out, and at the same time, how to get the complaints out. And some complaints have merits and some don't, but that's when it all comes to the top, and people can listen, learn, and people can back it up with data. But that's how it's done. And this is certainly one of the premier, or if not the premier, support group. Rick, do you have anything to peddle before you leave?
No, we're working on, I see an email just came in. We are working on a radionuclide therapy webinar for the end of the month, and Bing's sort of helping us with that, but maybe I'll know more tomorrow. It's going to be, if it happens, we're going to be doing it very quickly. We're also working on a solo arts heal with Mr. Burns for the end of the month, which will be great if we can get it going, but he's only recently back stateside, so we'll have to see if we can get that going. But other than that, thank you everybody for attending, and some great conversation tonight. It was a little bit of a different group, but it was excellent. Thank you.
Definitely was. Yes, thanks everyone.
Thank you.
Okay, well, with that, we're gonna sign off. It'll be an early evening. Yu is out in France and all over Europe, I guess. He's having a good time. I don't think he's back for at least another week. I will be out next week and the week after, because Trish and I are going to Ireland for our honeymoon. So I will be gone for the 2 weeks, and then after that, it's the 5th Wednesday. So we don't have a meeting the end of this month, at least at this juncture. That might change, and that'll have to come through headquarters, because it's above my pay grade.
I doubt it. We just want to make sure that you drink enough Jamesons and Guinness whilst you're over there for all of us, Gary.
Yeah, that's what they tell me. My father liked Guinness, and he was not like a Mick Ultra or a Mick Light kind of guy, Bud Light kind of guy.
Make sure you visit the Guinness factory, because that's definitely worth it.
Yeah, that's what everyone says, and I think that is on the agenda. So
Good. Yeah, it really is fun.
I wish everybody a safe and healthy 3 weeks, and I guess that's when you'll see my smiling face back on the.
Okay. Have a great trip, Gary.
All righty. Thank you so much, gentlemen. Good to see you, Jim.
Everybody.
Take care.
Take
We're
care.
gonna
Good
see
night.
a lot of faces tonight.
Good
Thank
night.
you.